Good evening, everyone, and a fantastic molecular oncology session which was going on. And I must congratulate Kumar, Vanita, and Dr. Anuradha for putting up a fantastic session, actually. And can I invite my panelists? My panelists are Dr. Bharat Jasani from Germany, Dr. Anuradha, Dr. Pratik, Dr. Amit Dutt from Mumbai, Dr. Rajiv Kaushal from Mumbai, the ever green, ever dynamic, always very well dressed Dr. Hemant Malhotra, Dr. Vikas Salreja, and Akhil Kapoor. Akhil, this is for you. Remember what I told you in the last discussion that we had. So be prepared. I hope everybody is here.
Dr. Ullas, did you ask Dr. Bharat Jasani to join?
Yes, madam. Dr. Bharat Jasani, yes.
Yeah.
Okay. So this is a hybrid model of a meeting which is going on. Except for the Omicron, I would also have been here, but maybe next time definitely. So we will be discussing about molecular tumor boards in oncology, and I think a fantastic conference which is going on. And when I first thought about a molecular tumor board in oncology, and I looked at the panelists which were there, my first reactions over there was like NGS report. I mean, that's an information overload. I mean, that's my first thing which we have been ordering NGS for a long time now. But my first thing which comes over there was an information overload. You have a lot of genes and all. When we passed our MBBS and MD, we thought, we are done with all these things. In oncology, it was easy as a theory to say we will do NGS way back in 2005. But again, we thought, you can always tell the patient it's experimental. But now we are stuck up with the information overload. My subsequent reactions at that time, again, in this age of too much information, and this is my reaction actually when I look at all the NGS report and all the genes which have been swirled at me, and I really hats off to all the molecular oncologists, to make a heads and tails out of it, and I hope they do. My final reactions actually on the NGS reporting in this, and on this panel is too much information. My idea of this panel discussion is understanding what I don't want to know. I think that's very, very important, I mean, as a clinician, as a medical oncologist, and as a molecular oncologist, it's a job to filter out the irrelevant 97% of information and give us the relevant 2-3% of information, both as a molecular pathologist and as a medical oncologist. So let me start with my molecular oncology people. Let me start with Dr. Bharat Jasani. Sir, molecular tumor boards in India, a fact or a fiction?
I think very much a fact. The impression I've got from this meeting, I'm utterly impressed with the fantastic knowledge, fantastic equipment, instrumentation, which is prevalent obviously across the whole of India. And this is a dramatic change that I'm observing because I've been to India several times before, and things are a bit slow to start off in immunocyte chemistry where I specialize. But looking at the molecular picture that you painted today, I'm very, very impressed. I actually went and told my wife, who was sitting next to her, that this is amazingly brilliant. So, very much a fact.
Okay, so from one stalwart to another, Dr. Hemant Malhotra, what will you tell your wife? Fact or fiction? Okay, you will tell a lot of fictions to your wife, but whatever molecular tumor board, what all will you tell, sir? Fact or fiction?
So, Ullas, thank you very much. You know that my wife is the chief of virology at the big government hospital, and she knows way more about NGS than I do. And
sir, to on that, sir, one second, sir. Even if your wife was not the chief of virology, she will still know. Everybody's wife knows much better than everybody else, sir.
Yeah,
that is another statement, sir.
And people of my generation and my age, they sync very much with your initial 2-3 slides which you showed. I think molecular tumor boards have to be a fact and not be a fiction, if not today, then very, very recently. And I think in the next year or 2 years, you will have molecular tumor boards in every good oncology center, whether you like it or you don't like it. So it's very much a fact.
So very much a fiction which is turning into an fact. That is what I am given to believe. Actually, let me take. So this was Dr. Hemant Malhotra. The very reason that Dr. Malhotra has been able to survive and thrive in so long years is that the willing to adapt to change. I mean, remember, I mean, if I talk of me passing out in DM in 2005 and then thinking about NGS being too much information and sir accepting it, from there to the very young generation of Vikas Talreja and Akhil Kapoor. So, Akhil, what do you say? TMC Varanasi, fact or fiction?
Definitely, sir. In today's world, it is definitely a fact now, and we need to adapt to it. We need to learn from it, and the way we mold ourselves and our knowledge, and we form a tumor board discussions that will definitely pave the way for improvement of patient care.
Okay, so fantastic. So, I mean, that's a very heartening change, in this pandemic of webinars, the last year when I did the same molecular tumor boards, almost all the medical oncologists said it's a fiction. We are not ready for it. And at least in 1 year time, so much of education, so much of knowledge has been imparted, and so much of the need to adapt to this change. I think we are all beginning to find that yes, whether we like it, it's going to be like Donald Trump, whether you like it or him or hate him, you can't ignore him. You can't ignore the molecular pathologist, Dr. Anuradha. I'm sure is smiling somewhere over here. I can't see her here, but I'm sure the molecular team at Tata is smiling away to glory, and rightly so. You deserve this accolades and stuff like that. So let's talk about molecular tumor board. I call this a battle of perspectives. The people over here the guy over here is looking at this saying it's a boat, and the person on the right side is looking at this and saying it's a land. So there are two different perspectives that a medical oncologist and a molecular oncologist actually share. Akhil seems to be agreeing with me, So Akhil, a boat or a land? So let me ask a clinician's perspective first. So I mean, honestly, it's not a very hunky-dory thing. It's not, everything is not absolutely fine. So Akhil, and okay, let me start with Vikas. So Vikas, sitting in Kanpur, let us say you have to ask for a report. When you ask for an NGS report, what exactly do you expect from the molecular oncologist, molecular pathologist? What do you expect from the NGS report? Vikas is there? Vikas, I can see Vikas in his graduation day uniform, but I can't see him as such over there. Okay, so Akhil, I think you can take this one.
Yes, sir.
So what do the clinicians want from the NGS report?
So we are brought up in a way that we want to know directly whether the patient is harboring any targetable mutation or not. So it should. We want to know whether we want to get a targetable drug to our patient or not. That is what we want to know. Also, whether if there is a targetable mutation, what are the chances of getting a response to the treatment? That means whether there are any mutations which are going to inhibit the action of a targetable drug. So these are some of the questions.
So just tell us whether, do you think, Akhil, except for the 21-page report that we get, they should just tell us 2 lines, like a PET scan report, metabolic active region in the gallbladder or in the right lung with mediastinal lymph node. Is that what you want? Then you will crib about, you're not telling about the remaining genes.
So definitely, if the answer is simple, then it is definitely easy. But it is not always so easy. Yeah.
Absolutely fantastic. We always will want to complicate things later. Dr. Hemant, sir, what do you want from the report? Do you want it to be like ER, PR, 8 positive or negative, or how do you want the report to be?
I think the most important factor over here, Ullas, is that the molecular pathologist has to be a molecular pathologist. He has to know his basics. So okay. If I have confidence in the lab and if I have confidence in the molecular pathologist, then I certainly don't want to look at the raw data and try to interpret it myself, which I know is near just about impossible. And I would clearly like to know what is the mutation, whether it is pathogenic or not, what are the FDA approved agents for it, what are the FDA non-approved agents for it. So if, in a couple of pages that information is provided to me, and I have confidence in my lab and in the person making that report, then I'm, quite happy with that, and I don't need anything more than that.
Okay, so I
Could
put
I
down
ask
the.
something to Hemant?
Yeah, sure, sir.
Yeah, Deepak, go ahead, please.
Yes. You want a one-page report or you want a 28-page report?
No, I want a 2-page report. If it is from Dr. Deepak Mishra, then I don't want to look at the rest of the 18 pages.
You want a one-line report if it's from Dr. Deepak Mishra.
Yeah,
But-
most
but-
a 2-page report.
If you have spent 3 lakhs for a foundation one, wouldn't you mind reading those 28 pages?
So Deepak, very, very frankly and very, very candidly, just between us medical professionals, I will leaf through all that report, but that is essentially for the patient and the patient's relative satisfaction. What I am going to focus on and make my decision on is the first page and the second page.
And sir, can Dr. Deepak, if this, I hope this is not being broadcasted, between you and me and only for our ears. 90% of the medical oncologists, I know it will be broadcasted, sir. 90% of the medical oncologists will not go beyond the first 3 lines, sir. The table which you write, they will only need for that, I mean.
What Ullas is saying is, I fully agree with him, they don't go beyond first page.
Yes, sir. But still we want 28-page report, sir. We will not go beyond that, but we still want that. So that is medical oncologist what to do. So I put up my wish list for the molecular oncologist. What does the clinician want? Simple, clear language. No medical molecular jargon. No clinical correlation required. Allah radiology people, increased bronchovascular marking, clinical correlation required. Just don't report for the heck of reporting. Please talk to us. Please talk to us. Ask us what exactly before you actually start reporting over there. This is almost like, we are asking something like an ideal man who doesn't drive, doesn't snore, doesn't watch football, doesn't argue, and I'm sure an ideal NGS report doesn't exist. So this is our this thing, but I'm sure the ideal NGS report is like an ideal husband actually, but it doesn't exist. Now let's go to the other side of the table. Dr. Anuradha, madam, you have been the one invited me, and I have been, taking away all the thunder from you. So what does a molecular oncologist or a pathologist or a scientist want from clinicians? So we told you what we want. Tell us what you want, ma'am.
Yeah, first of all, I would like to answer first question which you had asked whether it was a fact or a fiction. I would say both, because whenever you get some canonical mutations, then you feel very good. Yes, patient is going to have a treatment, but since many of the FDA approved drugs are not available in India, then you feel that whatever the mutations have come out, got detected, it remains as a fiction.
Okay.
So going back, coming to these questions, whenever the clinicians send us for the NGS test, we would like to know the patient's history and also what is the histopathology report, and accordingly we can go for the panels.
Okay, so you would want that's all you want, madam. You are a very nice, you are a sweetheart. So we will send all our patients to you only NSCLC, NOS. Please tell us this. Fantastic, madam. Dr. Pratik, what do you want? Something else?
So I made that openness from a clinician would be very much helpful. Openness to look at new information which is not familiar in the clinical field, and also to explore additional options through clinical trials and experimental drugs which are not really standard of practice, but they may be very helpful in challenging cases.
Openness. You are a typical, asking what a wife wants from a husband or a husband wants from a wife. You may not always get it through there. Dr. Amit Dutt, sir, what do you want from the medical oncologist or any oncologist?
So, thanks, Ullas. So, I have a slightly different perspective. I would want more of an educated response from a medical oncologist as well. Showing off for example, to say, as what Dr. Malhotra mentioned, that if the report is coming from Dr. Mishra's, Deepak Mishra's thing, then he's all okay with that. So that's something that I do not completely advocate, or I do not completely buy. These, and for the reason that there is a huge amount of plurality in the kind of reports that get generated in India. So one need to educate oneself that, and you need to kind of like see it. Need to know about the basic QC measures, that the report that has been tendered to you in your own capacity, you should be able to discern whether this report is which is trustworthy or not. Because of course, major decisions are going to be taken from there on, and perhaps there is going to be like clinical implications to that as well. So what I would expect from a clinicians too, I mean, further into what Pratik has just said, openness, I would expect basic understanding and a willingness
A willingness to learn.
yes, yes,
Okay,
yes,
fantastic.
not just kind of like accept it as an
Sure, sure, absolutely right. Dr. Rajiv, question?
Yeah, so first, I agree with most of the things which my colleagues have said. But in addition, I'd also like to know which are the areas of interest for you. So, are you looking for the for initial basic targets like EGFR, which you can target immediately, or are you ready to wait for a NGS report, which is going to take some time? So that is another important thing.
That is another thing. So I put together some points over there which basically said, again, talk to us. History is the yaar. Just don't write a NSCLC's pharmacy and find out what you really want to find. A good clinical. I know, sir. I mean, I'm guilty as charged. I'm a medical oncologist. Guilty as charged. A good clinical history.
I interject.
Sir, please.
The medical oncologists have no time to fill the test requisition form.
I would differ from that, sir. I would differ, sir. We need to, sir.
Write
We need to, sir.
EGFR mutation, sign below.
No, sir.
Information not there.
Not in my people, sir. I'll put them to solve.
You are from a different hospital where people are already primed about it. I will tell you, when we go for assessment of accreditation of NABL, whether the CAP accreditation, you see the TRF is something which is extremely important. It is hardly filled. Even if you send to standalone laboratory, you just ask for EGFR mutation, sign below. Nothing else there.
I totally agree, sir. It is almost like telling me, a patient comes to me कि मुझे बताओ cancer है कि नहीं है. हम मेरे exam ना ले रहे हो. I mean, that's wrong. That's wrong from the medical oncology point of view. And my point actually is, we are the people who are going to get benefited from that. And sir, conferences like this, panel like this, educate us, and we have tried to make a change over here, sir. We are trying to do that.
My second question is, will you wait for a reflex testing pattern for diagnosis, or you want everything on the platter?
So that depends upon, I can talk about myself, that depends upon who's paying for that. If the government is paying for that or the insurance is paying for that, I want everything. If the patient is paying for that, then sir, we will have a pre-test accessibility of whether how much you really want to.
So for lung cancer, what is your ideal turnaround time?
Yesterday? Just joking, sir. As early as possible. So the clinicians want the report yesterday. But the point is, I think 5 to 7 days is good enough. At least for the EGFR alpha. So what I do actually advocate is, if you ask me, the kind of things that I'm trying to incorporate in my institute, I'm trying to get an EGFR done by the COBAS PCR and by IHC. These two reports will come in 3 days time, sir. This will take care of my 43% of my mutations. If this doesn't come positive, I'll go ahead with chemotherapy, give one cycle of chemo, send the tissue by NGS. That's something which this is the model that I am trying to develop in my hospital. Hopefully, this is cost effective. What I'm trying to tell them is, let's charge for EGFR ALK and NGS for everyone. Let's charge a bottom line. You give us the report for EGFR ALK in 5 days time. Doesn't come positive, take a reflexy for NGS. Comes positive, tell me. I'll start on a TKIs.
And
my models.
Ullas, may I add that we would also like PDL1 expression level,
Yes, sir.
which again is a pretty quick report.
Dr. Hemant, that is the IHC, sir. Now, typically the molecular will be different and IHC will go separately. I mean, hardcore pathology and molecular people are totally different right now, sir.
Yeah,
that's what I would want.
That is an information what you would want, right?
Yes, sir. So that information, sir. So I'll tell you how do we do, madam. Just 1 second. When the patient comes to me first, I do a lung with reflex up to 4 IHC and PDL1. That's the billing that is done for. In 3 days time, I get my patient a PDL1 report and adeno or squamous. Once the patient comes on adeno, I would like to send for EGFR by liquid biopsy. The report may come in 3 days time since we do in house. ALK by IHC by 1 day time. In 7 days time, sir, ideally we can actually get to a basic things in which the treatment is available. Rest NGS 5 to 10%. Please pool your samples, give us the reports in 10 days time. Heavens are not going to fall because my one cycle of chemo will be there. That's the thing that I am trying to. Hopefully in next 15 days time we are doing to do in Rajiv Gandhi.
I totally agree with Dr. Ullas. Like EGF basic biomarkers like EGFR all should be in the lab, should be delivered by the lab within a week. So that
Yes, ma'am.
the deciding
then you pool your sample and then you take up all together. We have no issues with that. I mean that's absolutely okay with us.
Yes.
So good tissue tumor content. Patience is very very important for all the medical oncologists. And as Dr. Amit Das said, at least a basic understanding, I still remember, sir, we sent for a lung NGS panel when the panel was just starting. There was no BRCA 1 and 2 in that. It was not there, it was a small panel. And I fought with the molecular pathologist. I said, how is it possible that you are charging 45,000 rupees for that and you are not doing a BRCA 1? Poor chap kept on trying to make me understand. I was not willing to understand. So we as medical oncologists should know what is DNA, what is RNA, what is fusion is based on that. It's not very difficult, sir. I think we should be able to do that. And this is very, very important for medical oncologists. We should know what you really want before you're ordering a test. I mean, that's very, very important as far as I am actually concerned. Fantastic. So what should the report be looking like? I think we have done with it. I think we have just got 5 minutes. So I'll just have one case. A very important case. I'll run through this case and I'll ask everybody's opinion on this. A 68-year-old male, reformed smoker, non-small cell lung cancer, adenocarcinoma. He got chemotherapy elsewhere. A single gene testing was done which came as EGFR cross negative. The NGS tissue was done on the diagnostic tissue block anywhere else. This is the report which came to all my molecular oncology friends and my medical oncology friends. Please have a look. A coverage 100%, depth of 2443x. This shows the EGFR rare mutation and exon 18, but a VAF of only 9%. Somebody has reported as pathogenicity of variant of unknown significance. Now the problem over here is, so I'm just telling you all the things basically over here. This is a rare mutation which has been detected. Only 13 cases have been detected. Fair enough. Now, patient has come to us with this report. You have one pathology report, which is NGS report, which has said this. We sent a liquid biopsy at RGCI. Very impressed with all the molecular pathologists, which shows no EGFR mutation. You have an NRAS and a TP53 mutation. Okay. So you have two reports which are totally discordant. One is RGCI's report. One is reasonably okay report. We don't know whether to send or not. Since it was an EGFR report outside, we gave the patient afatinib. After 3 months, he had a progressive disease. And now, please mind it, he has a PDL1 of 90%. A repeat tissue biopsy done showed NACLC, NOS. Since there was a discordant EGFR report and a liquid biopsy report, I sent an NGS. And now my biopsy report is showing a MET exon 14. And honestly, this is what my reaction is. I mean, मैं क्या करूँ? I mean, somebody is giving an EGFR report, somebody is giving me, I'm going to keep it over here because these are two reports from my institute, one report from someone else. So, tell me, Dr. Amit, you are the one who is fighting the most. What do I do with this?
So, I mean, of course, I do agree with your the frustration that anyone would kind of facing these kind of reports which are so inconsistent with each other. But one has to kind of also see to that what you are really having on the table. What you get to see is an EGFR rare exon 18 mutation which has a very low allele fraction. So, first of all, I'm personally not aware of that, whether this mutation is activating itself or not. Nevertheless, so if it is at such low exon, low VAF, not picking it up in a liquid biopsy is not a surprise. Because liquid biopsy is something which is kind of a very sensitive technology, but then it also
depends on. Can I just stop you, Dr. Amit, here once? If it is such a low VAF, will my drug work for this? Should you then actually report in a tissue biopsy 9% pathogenic variant? You write VUS in a EGFR mutation, and this is a report I'm showing. This is an Indian report.
Right. So if I would have seen this earlier and with the PDL1 with 90% upfront that you have information we wouldn't have discussed to go for an afatinib otherwise. The PDL1 would have been a better way to go around with. When coming down to the VAF, which is 9%, 9% is low, but it is not kind of like something which is insignificant. 9% is still fine, and you can design a treatment, and that can be given, and then you can see a response that you get to see very often.
So, okay, Dr. Hemant and Dr. Akhil, sir, I mean, I'm sure you see all these things very commonly during your course of discordant reports over there. What do you do, Dr. Hemant?
So I think there's a very simple answer. If there is something which I don't understand, I talk to Dr. Ullas or I talk to Dr. Kumar Prabhat on the phone. But jokes apart,
Sir, हम क्या करें?
my personal take is that we are still in the process of learning. And like a tumor heterogeneity, we're all aware of that fact that tumors are heterogeneous. And the same tumor biopsies from 4 different, places might yield you completely different genetic mutations and genetic profiles. So it is not that maybe X lab is wrong and Y lab is correct. It can really genuinely happen also. I remember one NEJM paper in which they had looked at tumor heterogeneity in renal cell cancer, and the results were really astounding. So this is like a field in evolution, and once in a while we will have cases like this. And this is the time where we really need to talk to the molecular pathologist and kind of find a way forward. So there are no simple answers to this. There are no right answers. There are no wrong answers.
Let me talk to Dr. Bharat Jasani. Sir, what do you encounter these kind of things in your practice, and what would you tell your medical oncologist?
I think what I've heard is roughly what I would experience. As I admitted from the very beginning, I'm not a molecular pathologist, nor am I involved in routine work. So I think my reaction would have been the 90% PDL1 that was mentioned. And in light of the dubious results, although they may be important subsequently as we discussed, I would get the patient onto the drug therapy, on a first-line basis because it's quite a strong indication. So that will be my reaction to that.
Let me take Dr. Anuradha's and Dr. Pratik's opinion, and then I'll take Akhil's opinion, and I think that's the only case that will be discussed. Dr. Anuradha and Dr. Pratik?
So I made if we would have known the mutation status of EGFR way before patient received 3 rounds of chemotherapy, which you mentioned it was done somewhere else, then we would have done some more analysis using some bioinformatics tools and data mining, and we would have figured out that this mutation is actually not variant of unknown significance. Rather, there is a phase 2 clinical trial data available showing TKI sensitivity of this mutation. And if this therapy would have been started earlier, then the scenario might have been different. But I agree with you that in this present situation, if we'll end up into finding MET fusions at this stage, then this is difficult case, and perhaps changing TKI is the only option here.
No, so my take on this actually is, patient has got trust issues with this. We have got trust issues as oncologists. We have got trust issues. It's not a question of which. So the molecular oncologist here believes that all the reports are right. The medical oncologist actually, on the other hand, I'm putting it out in the open. We believe that we have been taken for a ride. Honestly, is it the right thing? Akhil, do you agree with me, or what do you say?
No, sir, I completely agree with you actually. So definitely how much we need to believe on the reports, we need to see that in detail. For example, Amit Dutt sir told that we need to have know some basic details to judge whether the report is valid or not. And with time we acknowledge that information and experience, and that is what drives us to know and join the molecular tumor boards actually. So there comes the role of molecular tumor boards. Otherwise it would have been just a simple report comes and we are starting treatment. So here is the role of molecular tumor board.
So Dr. Anuradha, as the convener of this, your take, you're the last word. See, medical oncologist take is on the right side. I got trust issues because people have got not lying issues. We have got trust issues with the reporting, Not everybody has the privilege of sitting in Tata Mumbai or a RGCI. What do you tell to a general medical oncologist, a community medical oncologist?
Yeah, that's what I say. The clinician has to look for to which lab are they sending, whether the lab is NABL or CAP accredited, and what is the performance of the laboratory. Can you trust, as Dr. Malhotra said, if it is Dr. I'm sending the sample to Dr. Mishra, then I can trust very well. So the trust is very important to which lab are you sending the reports. And there
No,
are
but
many.
what trust? No, Dr. Anuradha. Let's be honest about it.
Yeah.
There is a difference. As a medical oncologist, there are a lot of things that are there. Every lab comes to us, and this is okay. Fine, I'll show you this. This is what everybody comes and shows us. I am the best. I am the best. I am the best.
Yeah,
Everybody comes and tells us everything is NABL accredited.
But what but what I see from these reports, they have been sent to the various labs. So instead of sending to the various labs, we need to follow one lab where you can trust, and it has been done at a different point of time. Like the re-biopsy was done, then you got the met exon 14 skipping, and then the liquid biopsy was done. They have been done at different time intervals. So it's very difficult to justify.
Anuradha is
Yeah.
sticking to her guns. Madam, next Maharashtra elections you are joining. I don't know which party you are contesting, but you are definitely joining, ma'am.
But that's what I'm saying. You should trust the lab. You should have the NABL and the CAP laboratory to where to send the test for this testing.
So Dr. Amit Dutt has a point, and then I will ask the final comments to Dr. Malhotra. So, Dr. Dasani first.
So I just want to add a point that the basic endeavor for going for an NGS report should be to look for therapeutically approved alterations for which there is already a drug available and not as an explorative one. So if you're finding alterations where you're not aware of, then rather to explore and go for an experimental basis is not something that I personally kind of like a very fan of. If there is an approved treatment against an alteration, one should rather go for that. So in these kind of like alterations, I wouldn't explore, I wouldn't experiment around too much.
Okay, Dr. Hemant, parting word.
So as I said, this is a field which is evolving, and we are living and we are learning. But one thing which has definitely happened and which I think is going to refine over a period of time, that molecular oncology is there to stay, our molecular oncologists are there to stay, and we need to have a lot more communication and dialogue with our molecular oncologists and our molecular pathologists. Most of the situations are pretty clear, but there can be some situations which are very sticky. We need to have the patient on board, we need to have the patient's relatives on board, and we need to very frankly tell them that, some things we know and some things which we don't know, and most of them really do understand. So this is again the real place where local and possibly national molecular tumor boards may help. And I'd like to suggest to Dr. Kumar and Dr. Ullas, you guys are the leaders in lung cancer in the country. Maybe once a month you can have a national molecular tumor board in which patients like this can be discussed. And that will be a big benefit to all of us and to our patients also. Thank you.
So the same answer to Dr. Anuradha Chowgule. Jaipur, we know who is the next Chief Minister in Rajasthan. With this, thank you. And my summarization on this is molecular tumor boards are definitely a hub for learning. It's a must have in a dedicated cancer research center. It's a platform for learning. We need to have a healthy respect for the clinicians and the molecular pathologists. It's a team effort. The more I go to molecular tumor boards, the more I feel, the less I know. But ultimately, I'm beginning to learn more. I'm beginning to ignore. I'm beginning to know what to ignore and what not to ignore. But it's a fantastic thing. It's fantastic to be amongst this elite gathering of people, and it's a team effort. And thank you, thank you, and I hand it back to Amit. Thank you.
Thank you, Dr. Ullas, for making this very academic MTV meeting.
Thank